Hello, this is Oren Smith, Senior Fellow with Palmetto Promise Institute, and this is our briefing on healthcare. Since COVID hit, Palmetto Promise has been working on annual General Assembly to-do lists. Our first was called the Playbook, and it was a football-themed analysis of various issues that we felt that the legislature should be considering. And that evolved into the Freedom Agenda. And that's an agenda of items on a varied range of policy issues. And we try to track that as the legislative session goes on. So if you're keeping track of the legislature, which you may or may not, we're in the middle of a 2-year session. So there was an election in 2024. A new legislature, both House and Senate, was sworn in 2025. So the first year of the session is complete. So when the legislature comes back in 2026, the bills that were filed for 2025 are still in play. Now, they will have till the end of the 2026 session to pass. If they do not pass, at that point, in the spring of 26, they will be dead, and another election will be held in 2026, and then we kind of start all over with the process. So for this legislative session, 2025-2026, we produced this brochure that shows the issues that we feel are important, and we do them by category. Since almost the founding of Palmetto Promise, we have always used color-coded categories to explain the types of issues that we are interested in and to code those for easy reference. So if you go to our website, you're immediately going to see the topic we're talking about today, healthcare. And all the color red means healthcare everywhere on the website. Also in this brochure, red is healthcare. So we're giving you somewhat of an update on how we're doing for 2025, 2026 here at halftime for the legislature. So the topic today is healthcare, and this is an issue that we have gotten into as an organization more so recently because of its importance for the state of South Carolina. So we are going to go through a few slides here to explain where we are in South Carolina and in the country on healthcare. There is a columnist who writes for AEI, American Enterprise Institute, and he referred to the chart that we're showing here as the most important chart in the world, or the most impactful chart in the world. And he updates it regularly to show the impact of prices, how prices have changed. And here we have from 2000 to the present. That's Mark Perry with the American Enterprise Institute. And when reforms to healthcare policy were in play in the last few legislative sessions, we used this chart regularly. I remember a number of legislative meetings when the question became, do we pass a healthcare reform, or do we just continue to go about the way we've always done things? And one of the key members of the legislature slid this chart across the table and challenged those in the meeting to do something about healthcare in South Carolina. So as you can see, and AEI's perspective is always going to be free market as ours is, but you see those in red, those that are growing in price and becoming more expensive, with hospital services being number one. And these are all categories that are tracked by the statisticians with the federal government, and AEI is just using those categories. And you see those that have become more affordable. There's a commonality here. There's a trait that is involved, and that is those in blue that are flat or going down. There's not a lot of government involvement. Government is very much entangled with healthcare in this country, as you know, and so part of that is why we have the giant increase we have. And for those of you who may have students in college in your family, or you're a college student, you see right there that college tuition and fees are right there with healthcare. And we will talk about that in our education policy briefing, which you can access at this site as well. But let's get into some of the healthcare issues that we want to talk about. They're a part of our freedom agenda. As you can see, this is a general outline of what we're going to try to do today, and that is we will talk about some general categories: telemedicine, price transparency, scope of practice, a little bit about agency reorganization, and then some other healthcare policies that have collected since we last did this broadcast in about this time, November or so of 2024 is when we did this before. So here we go with these issues. And first of all, telemedicine. So South Carolina healthcare policy, our policy on telemedicine. And there are organizations that we really trust to help us with our analysis here. And we want to talk about what they think about our healthcare policies. But there have been some recent reforms to telemedicine. Probably the most significant was when we carved out social workers, professional counselors, and other mental health professionals so that they could practice relatively unfettered through telehealth. So that was a very small sliver of healthcare, but the mental health crisis and public schools in general were calling for help, and the legislature heard the people of South Carolina on that and provided that carve out. A good step toward more significant upgrades and changes in telehealth was that Telehealth and Telemedicine Act that passed in 2024. It's mainly a cleanup bill, codifies what telehealth means, what telemedicine means, provides some flexibility for nurse practitioners and some other cleanup items. It was something we celebrated, but we felt that maybe, I guess in football terms, we kicked a field goal when we really would have liked to have had a touchdown on that issue. But we will cover some more about that as we go along. So the Cicero Institute, who was relatively unknown about 5 years ago, maybe they hadn't even been formed 5 years ago, but Cicero has started with an expertise in healthcare, and they've expanded from there. As we move along here, we're going to come back to Cicero's influence on federal health policy, but they did a study of the nation as far as telemedicine goes, and they said that South Carolina did some things well. The modality or the way that the telehealth actually is provided electronically, they found to be fair. They were complimentary that we were members of healthcare compacts or associations of medical medical practices across state lines, which is very helpful for portability. The range of providers that can use telehealth, they were very positive, except they said we really don't truly have healthcare freedom across state lines. And that's kind of what I meant about the field goal rather than the touchdown. We would really have liked to have seen that. So that's what we have from Cicero. Cicero, even though they like some things, they still rank us an F, and that's because of we need to strengthen our modality beyond what they liked. There's some problems. They really wanted the ability for telehealth to be initiated or started by any mode. Like, for instance, if a person were in a healthcare crisis, would they be able to use their smartphone to text and begin a process of true telehealth in that manner? The way they see it and the way we tend to see it is our current law really doesn't do that. There are also these barriers across state lines where we're hearing of college students who are in at a university in another state. Their physician is back in South Carolina. They have to head for the border of the state, cross the border so that they can participate across state lines in telehealth. Some of these oddities that have crept in. And again, we don't really have the flexibility for nurse practitioners that some other states are starting to get. And we'll go a little bit more into scope of practice here shortly. But that's generally what we're looking at about telemedicine. Now, price transparency is an issue that I think, honestly, Palmetto Promise Institute was one of the first organizations, particularly one of the first state organizations in the country, to push really, really hard for price transparency. And another way of calling it is surprise billing. And I just think this cartoon says it all. Here's this poor fellow. He's got his oxygen tank and his cane. He's clearly arriving home from the hospital. Welcome back. You are still alive. You made it through the hospital. Welcome back home. And oh boy, look what's come in the mail. And essentially, for a lot of South Carolinians, this is how they find out how much they owe for the service that was provided to them. Remember, my own family was attempting to get a feel for what a medical procedure was going to cost, and continued to call the provider and was told it's too early for us to predict that cost for you. So there's just really no way to know, no way to budget. And there are ways around this problem, some of which it's just a matter of raising awareness among South Carolinians. But the legislature could do some things to make transparency a thing. The executive order on federal price transparency we had under the first Trump administration. In fact, some South Carolina physicians were present for the signing of that executive order under the first Trump administration. We're looking to see what other executive orders may be on a tap in this area. And there are lots of ways of banning surprise billing. But what we found is, depending on what approach you use to it, whether it's something connected to requiring, say, a hospital to provide a bill within a certain period of time, or for a bill that was considered a surprise bill to not have an impact on one's credit score. Different strategies for it. And something's interesting about this whole topic, by the way, is the bipartisan nature of it. At one point, we had Republicans in one chamber and Democrats in another chamber filing bills. So it clearly has some resonance with the public. Right to shop was a popular theme a few years ago that we're attempting to revive. New Hampshire has used this program. It's the ability of a patient to, if they take the trouble, if they use the sweat equity, so to speak, of looking around for the best price, then that can benefit them financially. And in some cases, it could benefit them through their health insurance. So their insurer or would receive a benefit as well. So they would share the savings. Different ways of doing this as well. And we've had South Carolina bills about right to shop. Still needs to be perfected, but it's certainly a concept that makes a lot of sense and would encourage this price transparency. I want to talk a little bit about scope of practice. This has become a red hot issue. It's a good thing healthcare is red, and here you have the red there standing out with scope of practice, because it's become a red hot issue in South Carolina. The South Carolina Senate in particular, the Medical Affairs Committee of the Senate, which, committees of the General Assembly, if they are meeting during the off session, which is roughly, say, late May through December, if they're meeting at that point and they're holding committee meetings and subcommittee meetings and having hearings about legislation, that indicates, or it's a pretty good indicator of what the leadership of the House and Senate, what they feel about the issue, how strongly they think the issue resonates with the public, and how urgent they feel something needs to be done about it. And this has certainly been the case with some of the members of the Medical Affairs Committee in the Senate, which have had multiple hearings on scope of practice. So let's get an idea of what we mean by it. Here's a kind of a lawyery sort of definition, but a scope of practice are those activities that a person licensed to practice in the health field are permitted to perform, which is determined by state statute, that meaning legislatures, but also rules adopted by licensing entities. So the legislature and the state board of medical examiners would have a role in this. We put it in our 2023-24 agenda, which was the one previous to this, that South Carolina should trust proven professionals to do their jobs or to practice at the top level of their training. So if their training is at this level, they should be allowed to practice at that level. We'll refine what that means here shortly. So, South Carolina, our healthcare access, the access of the average South Carolinian to healthcare, or the average, or the access to healthcare of a rural versus an urban resident in South Carolina. When all of that is averaged, what we get is that we're 37th amongst 50 in access to primary care providers. We're even lower for access to mental health providers. And then we threw in dental here for you as well, because it's even a little lower to dental providers. But the collector of all South Carolina healthcare statistics is the South Carolina Area Health Education Consortium. And that is where a lot of the data that you will see mentioned here, and the data that was presented to that subcommittee of Senate Medical Affairs, came from AHEC. And they are absolutely the source of this type of information. They say that we have not only a shortage problem, but a maldistribution problem. And as I understand it, what that means is we have too few medical professionals, but also if we were to redistribute medical professionals more evenly, then we would have better coverage. But just the nature of the state, the urban areas have better coverage for health than rural areas. So there's a maldistribution. We look at the types of medical professionals that we're generally talking about here. Now, we'll talk a little bit here soon about pharmacists and some other medical professionals. I think we've already covered everything we're going to say about dentists, but generally we're looking at three primary providers of healthcare in South Carolina as far as generalized medical care. Physicians, of course, your doctor. In America, doctor and physician are kind of interchangeable, but physician is really the correct term. He or she may have an MD, doctor of medicine, or whatever that is in Latin, or may have maybe an osteopath, so maybe a doctor of osteopathic medicine. These are the people that you, in the medical sense, would call doctor. There are about 14,000 physicians in South Carolina, which is a ratio of 25, 26 or so per 10,000. And most physicians, they're practicing in private offices, they're doctors' offices, as we have always said, or hospitals. And training for physicians, need we emphasize, training for physicians is rigorous. We're going to cover a chart shortly to show a comparison, but 12 to 16,000 clinical hours, that doctoral degree, the residency, the licensure exam, it's significant. It is rigorous, and that's the top level of the healthcare providers, and that's the physician. Now, also in South Carolina, we have, I'm sorry, I forgot about this one. This is to give you an idea, we'll come back to this. This is to give you an idea of coverage for physicians, 10 or more. You see Greenville there, you see the counties along the coast, you see, let's see, Richland there with primary care physicians in that dark blue, but in red, you see counties like Union and Chester, some of the counties around that are more rural, that do not have the rate or the percentage of care per 10,000 there amongst physicians. So this brings us to nurse practitioners and physician's assistants. So nurse practitioners, these are advanced practice registered nurses. So they are registered nurses. Their training follows a nursing model. The analysts of nurse practitioner practice and policy would say that in South Carolina there's a restricted practice. Restricted in that sense means they do not practice completely independently. There is a relationship with a physician. It is a cooperating relationship with a physician. And this is, we're going to see a map here shortly, but that's generally the case in our part of the country. They do have their own prescriptive authority. through the Board of Nursing. They have their own DEA, federal DEA licensure. There are about 6,600, 6,700 APRNs in South Carolina. Most of them are nurse practitioners, 5,260 certified registered nurse anesthetists you've probably heard of. Clinical nurse specialists and nurse midwives kind of round out the types of advanced practice registered nurses in South Carolina, about 12.9, 13 APRNs per 10,000 residents. So of those advanced practice registered nurses, 79% or so, roughly 80%, are nurse practitioners, which gives us a rate of about 10 per 10,000. And here's how you can see the breakdown of when someone is an advanced practice registered nurse. Well, specifically what? Well, usually a nurse practitioner, but also a certified registered nurse anesthetist, certified nurse midwives, and then clinical nurse specialists. So these are those four types of advanced practice registered nurses. And for the most part, sometimes the certified registered nurse anesthetist is separated out. But for the most part, these are the specific occupation certifications, job titles we're talking about that are a part of this reform that's being discussed primarily in the Senate. So let's go on to physician's assistant. Physician's assistant, remember, PRN follows a nursing model. This follows more of a medical model. The physician's assistant, and as best I can tell, a physician's assistant, which is a little bit of a mouthful, is kind of going away, and PA is becoming the general term now to speak of this job title. There's a supervising physician, which is a little different than an APRN, which is more of a cooperating relationship. This is a supervising physician. There are about 1,800 PAs in South Carolina. Most of them work in physicians' offices, hospitals, or clinics. About a quarter of them work in primary care. And here's some interesting, I think, very interesting statistics about the ratio and also the growth level. So South Carolina PAs per 100,000, we're 30th in the United States. So 30th out of 50. But when you look at the percentage growth from the period that we're looking at statistics here, 2018 to 2022, we're second. So physician's assistants, while we're in the back of the pack, or three-fifths of the way back, we are ranked second in growth. North Carolina is ranked fourth in actual ratio of physician's assistants to population. So right over the border, there is a higher ratio of physician's assistants to residents in the Tar Heel state. And there are 5 PA programs in South Carolina. By the way, everything that we've said thus far about scope of practice, this is in a recent paper, a recent white paper. Don't be intimidated by white paper. I know that might mean you could use it as a weapon because it would be so heavy. But this is a very short white paper that you could read very quickly, but it contains all of this information. In fact, it's more specific in some areas that we're able to go into here in this short video. So I'd refer you to that to go in a little more depth about this. And it's available on our website. Once again, if you click the red section, the red area, which is the healthcare area. So here's a comparison of the individuals and the types of job classifications that we've just discussed. When you look at the different medical professionals in South Carolina, we added RN, since RN is a step toward advanced practice RN. But as you can see, a medical doctor must have a residence of a certain number of years, those clinical hours, 12,000 to 16,000. The APRN, again, has a college degree. There are advanced degrees required. Within 2 years of getting that degree, they must be certified. Now, technically, they're not required to have a typical fellowship or residence the way a physician does. The total number of clinical hours is at least 500, but can be up to 750 or slightly more. The being very specific here, the physician's assistant C, for being very technical here, there are 3+2 degree programs available so that you can earn your bachelor's degree along with a PA master's degree, but there are other ways of getting a PA as an undergraduate, and there is a graduate degree required, and there's a national exam required. So again, there's no fellowship or residence in the sense that a physician would have, but there are some optional options for that. Clinical hours, 2,000. To be a registered nurse, an associate degree is sufficient. There's no graduate degree required. There's no fellowship, and then the hours are 500-ish to 700. So that's an idea of the training, both undergraduate, graduate, fellowships, and total number of clinical hours that are required to practice. So the National Council of State Legislatures has done some analysis of how the 50 states differ. And this is always an interesting part of our work at Palmetto Promise, is to see how the laboratories of democracy, the 50 states, they handle lots of things very differently. In some states, you can't pump your own gasoline. You have to have an attendant come out and pump your gasoline. That's kind of going away, but you still have a few of those. So every state on every kind of policy you can imagine has different ways of doing things. Sometimes I think in South Carolina, there's this way, that way, and then the South Carolina way. But just it gives you a visual here of what the laws are about advanced practice registered nurses and PAs. So does the nurse practitioner have practice and prescriptive authority? As you'll see here, South Carolina, a physician relationship is required. That bottom darkest blue, that cobalt blue, a physician relationship is required for an APRN, and that's pretty much the case in the Southeast. Florida has made some changes that allow an advanced practice registered nurse to transition to an independent practice and enhance prescribing authority with certain standards about training and time are met. So Florida's probably the most innovative, as they are on a lot of issues, but they're probably the most innovative in our general area. But this gives you an idea. The West, as you see in red, full independent practice and prescriptive authority. The West has a very different view of APRNs than most of the Southeast, and the Northeast, of course, is somewhere in between here. If we look at physician's assistants, it's generally much tighter than APRNs, but here's supervision requirements. And this, again, is from the National Council of State Legislatures. Collaboration is required. Let's be specific. Supervision with a physician is required. That kind of powder blue or light blue covers most of the Southeast and the Midwest. There are some freedom with some of our border states, Tennessee being one, but this is generally a little more mixed for physician's assistants for practice authority. Then if we look at the number of physician's assistants that may be supervised, and this has traditionally been a part of this legislative area, providing a number in the law or in the regulation on how many physician's assistants or advanced practice registered nurses can be supervised. And that's supervised or collaborated with by a physician. So in essence, you add together the PA number and the APRN number, you get a number, and then what does the state law say about how many a physician can supervise? And changes to that number have been a type of reform. As you'll see here, the statute in South Carolina limits the number of PAs and APRNs that may be supervised. Those that are in blue, that's not in the statutes. and it could be determined at the practice level. The practice may actually determine the number that they feel for their practice is a good number, but in South Carolina and most of the Southeast, it's in the statute. And here's proximity. This is another issue. How many can be supervised, and how close by does the supervising physician have to be to the APRN or the PA? And in this case, PA, adaptable proximity. What we're essentially saying is the statute allows some type of proximity that does in this case normally means the physician does not need to be physically in the building or within a certain number of miles. Now, South Carolina law used to have a mileage number. The physician may not be more than a certain number of miles, but with modern technology, stating a number of miles seemed a bit arcane, so there have been reforms to our law on that. So what is a reform? What is an answer to the need for more healthcare in South Carolina, particularly in rural areas, and this essential tug of war between many physicians who feel that physician's assistants and advanced practice registered nurses are trying to become doctors, are trying to do more things that doctors do that may compromise patient safety in the view of many physicians. That's in tension with the idea that PAs and APRNs could help fill this gap, particularly in rural areas, and there could be areas in which they could practice that would involve less risk. So we felt at Palmetto Promise that it's our role to propose ideas and to propose solutions. Sometimes, because we're not medical professionals, we're not physicians, we're not people that live healthcare policy on a daily basis, hour by hour, minute by minute. Sometimes throwing out an idea is something I think that maybe we're uniquely qualified to do as a generalist policy organization. So the way we looked at this is to look at the types of PAs and APRNs, the areas, the physical geographical areas of the state, and then what type of patients do we have. So if we take a Venn diagram and these if you're able to manipulate these actually physically, you could move these around and you could label them different things to specify exactly how it would work. But what we proposed recently was that if the patient is a relatively low risk patient, and if the patient is in an area where there is a healthcare desert, and if this advanced practice registered nurse or if this physician's assistant has an extremely high level of education, has taken certain types of courses, has had a certain level of clinical practice hours, so something with hours and education experience. So not an entry level APRN or PA, not someone who just recently received their ability to practice, their license. Something that's unique that allows us to solve some of these problems without putting patients at risk, without removing the fact that some patients absolutely need to see a physician or need to see an APRN or PA that has a relationship with a physician within the current law related to the supervision of those medical professionals. So this was our idea. We certainly understand that it is open to revision. It's open to complete change, but at least it is an idea that we believe is freedom oriented, that is about the market, expanding the market as we did for some other issues that we've worked that we'll talk about shortly. But that's what we call our modest proposal that we stole from English literature. but that's a framework we think for moving forward. So here we've included that map again, just so you don't forget it. This is that primary care physician uh, number, that ratio. It's so different. I mean, if you drive, it's kind of difficult to get from Greenville to Union by highway. You might have to follow GPS around to find your way from Greenville to Union. But as the crow flies, it's not really that far. But look at the difference: 10 or more primary care physicians per 10,000 in Greenville. And different parts of Greenville will be different, though the counties become very urbanized and suburbanized. But then there in Union, not so far away, zero point 0.1 to 2.9 physicians per 10,000. Very short distance, but a lot of difference in care available. And our modest proposal is a way to help solve that problem. So I don't expect you to be able to read this, but let me just describe to you why this slide is a part of our presentation, and that is these are the standards that were released by the Trump administration Department of Health and Human Services in their rural grants program. So these are the standards by which you can get extra points, because it's a points oriented, at least part of the funds from the Rural Health Initiative. Part of the funds are competitive. The grants are competitive. And South Carolina just recently submitted our grant for the competitive portion of the rural grant program from the federal administration. But as you'll see there, right about in the middle, it says scope of practice. So you can get extra credit or get good credit on your application if you have expanded scope of practice in some way. So in our modest proposal, we were saying, if we make some change in South Carolina, is there a possibility we can get some more points on our application for that reform, for that change? And if you really can read the small print, you'll see that the aforementioned Cicero Institute is the standard that the administration is using for some of these, including certificate of need. And I think we have some about CON here as we're moving toward the end. But that's a reason to do it, because there may be more money in play if we can do it safely. So one reform that we advocated was to reduce the bureaucracy, streamline the cabinet, and in some ways bring agencies into the governor's cabinet that before had a board that they reported to. Let these report, make the governor responsible for excellence in those healthcare areas. And it started in one way and one method, and it ended up in another. But this was the original proposal from 2024, where the health agencies would be combined into an office of health and policy. So you had 1, 2, 3, 4, 5, 6, 7 that were combined. You had a single cabinet member that was responsible for a vast part of the state budget. This was because the Department of Health and Environmental Control had been split between health and environment. So this was the next step. But this is what was actually signed into law in 2025. And as you can see, it was S2. Sometimes you can determine the legislature's priorities by how high, how low the number is. So number 2, the second most important issue to the Senate, because it's an S, was this combining the health agencies. So now we have the Department of Mental Health, Department of Disabilities and Special Needs, Department of Alcohol and Drug Abuse now under this new Department of Behavioral Health and Developmental Disabilities. So it's much simpler for the governor to oversee. We still have the Department of Public Health, Department of Health and Human Services is primarily a Medicaid agency, and the Department of Aging. So those were not combined, but some streamlining did occur, and we were very glad to see that. So what next steps are there in improving the way health care is delivered and how the state government fulfills its role in public health in all of these areas that relate to health. Agencies are finally under one roof. They're sharing data. Someone that has one type of need, but also another type of need in the same home or same family, no longer, in most cases, will they be seeing separate agencies and attempting to get help for various problems. And the governor made this point in his State of the State speech, where he called for these agencies to be combined. Now it's easier for South Carolinians to get access. But what's the next step? What else can be done? Well, there are policies that are known around the country as one-door policies. And these streamline the assistance even more. It streamlines all government assistance programs, intervention programs, workforce development related to jobs. So someone can literally walk into one agency for help and be connected with all these resources. So this is good for government because it streamlines further, but it's also good for a person who is struggling because they will have all these agencies in one place rather than literally driving or getting a ride all over town, seeing various agencies to try to get to the point where they can eventually be independent of all of this government assistance. So one door, literally one door you can pass through to do that. And Louisiana, a state that has in some ways more socioeconomic challenges in South Carolina, they are a pioneer in this effort. And Utah, which is very different from South Carolina, but they are they're very reformist when it comes to governmental policies, and they have also led the way. So Utah and Louisiana, we would suggest, are models for the one-door policy. So as we come around to toward the end of our time together here, let's cover some other healthcare policies. Maybe we'll call these miscellaneous type policies, but look at a few of those because they're all important. The drug supply chain, as illustrated in this graphic, if I were able to do a poll right now of everyone who is listening to this presentation, I would love to know if you've ever heard of a PBM. Have you ever heard of a pharmacy benefit manager? A PBM essentially is in between your doctor, your pharmacy, and your health insurance. They're another entity involved in this, which for the insurer, it assists the insurance company in delivering the drug that is most helpful to them financially. The doctors sometimes can be frustrated because, in essence, the PBM has intervened into that relationship. So a lot of potential problems here. There can be rebates from drug manufacturers for prioritizing these drugs for being prescribed. They can charge some patients more than others, and then some organization, possibly the PBM, could pocket the difference in price. It's the whole idea of what is a specialty drug, who can sell them. What if the pharmacy benefit manager owns a pharmacy chain? It's a lot of, as you can see, it's a wide range of interactions, some of which are inappropriate if we're looking for the best care for the patient. But this PBM concept and the PBM policy has become a topic of great discussion at the South Carolina State House. Federally, there's been federal legislation. So the Palmetto Promise Institute, one of our brilliant research fellows, Spandana Ankuri, wrote a short paper. Again, it's a white paper, but it's not a doorstop. It is a very simple, go to the bottom line explanation of what the PBM is and what types of reforms are needed. We highly recommend it to you. It's on our website. We feel that the PBM industry is monopolistic. We don't really like monopolies in energy. We don't like them in education. We certainly don't like them in healthcare. And it really puts a strain on competition. in the pharmacy industry, and it's hurting some of the small pharmacies. If you're the PBM and you own a chain of pharmacies, and the independent pharmacist in your community that's not a part of that large chain could be squeezed out, and could their prices could not may not be as competitive if this PBM concept is not refined. So there's several different reforms that are available, and we describe those somewhat arcane but important reforms in that paper, the PBM Power Play, which we recommend to you. There's also the idea of portable benefits, and this is I want to give a shout out, make sure I have this correct, but everyone's heard of DoorDash. DoorDash is a leader in this. It essentially means that if you are moving from job to job, if you're a gig worker, it means that you don't get left out of the idea of actually having some benefits that carry with your workforce participation. So independent workers would be able to access health care, retirement plans, all of those things that are important, paid leave, even though they may not be working for a single employer, or that they may move, which is the reason that was called portability. And this is really important for gig workers. So contributions could come from multiple hiring entities into one central worker-owned account. So these are voluntary contributions by employers for these things that we mentioned: healthcare, retirement, paid leave. So as you can see from this graphic, and again, we have a marvelous short explanatory post in our healthcare section of our website on the continuity of care and what it requires for independent gig workers. Gig workers are a huge part of our economy, as you can see, particularly since COVID, but even slightly before that, independent work was on the rise. And it really is not good for our economy for a person who is working various jobs or moving from job to job for legitimate reasons to just completely miss the opportunity of having that relationship that provides health care, that provides retirement, that provides time off, that type of thing. So this is just a logical, thoughtful approach to how our economy is changing, and to protect workers who are not typical 1950s style workers. This is a 21st century model to help the workers get benefits that they deserve. And it is optional for the employer. So non-compete agreements, good, bad? First of all, what is a non-compete agreement? Well, a non-compete agreement is the idea that if a healthcare organization, I don't want to pick on hospitals necessarily, but it's easiest if you think in terms of a hospital that hires a physician, and that physician finds that there is another hospital or there's another healthcare industry or healthcare provider that is a better fit for that physician or any type of person who serves in the healthcare field. Can the current employer essentially ban or penalize that physician from moving? Can they essentially be trapped because of these non-compete agreements? So trying to think of an example from another type of occupation in our economy. Let's say that your favorite weather person were on the nightly news as the chief meteorologist for that television channel. And suddenly they decide they want to move to the affiliate of another network across town and become their chief meteorologist. Sometimes there are these non-compete agreements that would prevent that. It might actually mean that this person whose specialty is weather and meteorology may have to move to a different market entirely, maybe even to a different state. Well, the idea is sometimes hospitals may have invested in the physician, maybe say paying some of their student loans for medical school, other things that would make sense for there to be some protection for the hospital. But sometimes it is not that at all. It's either golden handcuffs or just simply handcuffs. So we're advocating that we study this, that the market needs to be freed up, that non-compete legislation would protect physicians and their professional and their personal lives, and patients' rights to be safeguarded because they would receive a consistent, high-quality care. So it's a complicated issue, but we don't want physicians to be trapped for no reason in their positions when they would be able to thrive elsewhere. Certificate of need repeal. Just once in a while, we need to tell you how some of the reforms that have passed. So, how's that going? We do a lot of work in education. When the education scholarship accounts or education savings accounts passed, it became a different issue entirely. It was, how is the program being administered? Are there going to be customers for the program? So there's a reporting requirement. There's an implementation report that is required. And I think of all the issues that Palmetto Promise has been involved with over the years, certainly the certificate of need is one of the most significant. It simply meant that South Carolina removed the requirement that a healthcare organization needed a permission slip from government before they could establish a program or build a building. So I don't know if you've driven around South Carolina lately and noticed the building of healthcare facilities. I've noticed them all over the state. I've noticed several in Anderson County, several in even in Marion County, Horry County, even in downtown Columbia, not far from our office. Some of those new hospitals are going to be popping up. And one technicality about this removal of the requirement for the certificate of need, there was one type of facility that had a little more time before the CON repeal affected that type of facility, and that's the big one, the acute care hospital, the major hospital that provides nearly every kind of care that there is. That provision does not kick in until the end of next year. So we're not seeing as many new full service hospitals, but we are seeing the proposal of University of South Carolina Brain Focused Hospital. Navant now is in Bluffton, Prisma Behavioral Health, and Pickens, McLeod, and Sherraw. There are two Lexington Medical Center facilities that we've seen, MUSC, Roper, ANMED. Really, there's a long list of facilities that are being built. So healthcare is going to be more available to you and your communities, particularly some of these rural communities. It is really heartwarming for us after advocating this policy to see that that these facilities are popping up, and certificate of need is mostly dead, and it's going to be completely dead soon in South Carolina. So it's very exciting. So just as we're getting toward the end here for our wrap up, and we're hoping to get you finished here in roughly about an hour, just some of the things that we've discussed sort of as a summary here of some of our healthcare policies that we are interested in. Certificate of need repeal, it's the most significant in America since maybe Pennsylvania in 1996. I mean, South Carolina's repeal was really significant. Make sure you understand that. And we thank all the members of the House and Senate who started in favor of CON repeal or eventually came around to CON repeal. The telework or the telehealth policy, we think moved in the right direction when it came to psychology and some of those areas that were sorely needed. There's been some scope of practice reforms. making it easier for APRNs and PAs to practice in South Carolina, and that health agency restructuring. Those have all been positive. But as we're looking, and there's always going to be a long list. If there's anything that Palmetto Promise, maybe we're famous for, is to always have a ready list of reforms that we're recommending. We think that scope of practice reform, particularly our modest proposal, would be an excellent way to expand healthcare in South Carolina. We think expanding telehealth beyond state lines, reducing that barrier, knowing what you're going to pay for a service before the service is performed. It just seems logical. So banning surprise billing and moving toward a pure price transparency model. We did not discuss, but this is on our website, a marvelous blog post on this, but some physicians who come to America internationally, there's certain of those physicians that have the type of training that we could get into the healthcare provider pipeline more quickly. Don't know if you're aware of direct primary care. Direct primary care is essentially when you sign up for physician services, very similar to maybe getting a gym membership where you pay a monthly fee and you can go as often as you want. Very similar, direct primary care. And we have description and explanation of this on our website as well. But it's when you subscribe to a physician service and you can use as much of that health care as you wish for a set monthly fee. We want to make sure that somehow direct primary care doesn't get turned into something regulatory or in terms of regulation that makes it seem like insurance, because it's not insurance. It's a membership in a medical provider organization. So just want to make sure we protect direct primary care. Back to the non-competes, we discussed that. We need to make sure we look at that so South Carolina is not unnecessarily shackling physicians and their ability to practice. And then finally, and we didn't speak of this much, but the idea of pharmacists having more authority. And we have a great blog post on this as well. I keep referring you back to our website, but we write about all of this on a regular basis. This is essentially, and some policy professionals don't like this term, but I sure think it makes a lot of sense for explaining generally what is being done. Allow a pharmacist to test and treat. So if there is a test for a certain type of illness, the test can come back making it clear and plain that the patient who has come into the pharmacy has this illness, then they can treat using standard medications for that illness. That's a dumbed down version of it. You can read more about that on our website, but it's empowering local pharmacists. It's an untapped resource in South Carolina, and if legislated properly, for instance, North Carolina has a version right over the border that they just passed. There are ways of legislating in this area that can expand help for some of the more simple health issues for which there is a test to allow pharmacists to help with the treatment. So that's our hot list, and all of those are discussed on our website. We encourage you to take a look at those. So that is generally our briefing for today. I don't know if we have anyone who is online as we are presenting this originally that might like to ask a question. I'm going to just look for a few minutes here to see if we have any questions, but if not, it looks like we have hit the 1 hour mark here, almost on the button. So again, the Palmetto Freedom Agenda, one last commercial for the Freedom Agenda. We hope you'll take a look at our website. This brochure is available there in printed form. Each of our issues in the brochure, if you see that, has a QR code that you can use to navigate our Freedom Agenda. But if you're on the website, you won't even need that. Just follow the icons for healthcare, tax, education, quality of life, and you can see what our research has indicated should be the policy priorities for South Carolina as we finish out this legislation and go into a new legislature for the next meeting of the South Carolina General Assembly. Thank you for being with us today. And of course, if you have any questions at all, everyone here at Palmetto Promise is available to you by text or email or by phone, and you can find our contact information on the website. Please do not hesitate. If we have misstated something here, we certainly will be able to correct that and as a part of this video, but also if it's led to further questions, we can only go into so much depth today. We can go into further depth with you on a one-on-one basis, so don't hesitate to contact us. That's it here from Palmetto Promise. It's been a pleasure to be with you, and we look forward to other presentations like this, which you'll find on our website, and hope you'll make use of those as well. Have a great day.